Hi, my name is Mastrianni. I'm a PhD student at Drexel University, and today I'll be presenting on designing interactive alerts to improve recognition of critical events in medical emergencies. In pediatric trauma resuscitation, a multidisciplinary team of providers cares for a critically injured child during a short window of time. A senior resident or fellow serves as the team leader, guiding the team through the advanced trauma life support protocol. In past work, we created a digital checklist for leaders to use during their resuscitation. The checklist is based off the ATLS protocol and has the tasks that should be done in each phase of the protocol. The checklist also has a place for the leader to record the vital sign values. Vital signs are critical for determining a patient's clinical status. However, in our past work, we found that vital sign documentation on the checklist was often delayed or not done. In this study, we introduced a set of alerts to improve timely documentation of vitals on the checklist. On the right-hand side of the screen, you can see the vital signs section of the checklist highlighted in red. Our alerts focused on 4 vital signs: respiratory rate, blood pressure, oxygen saturation, and heart rate. We used 2 alert modes: pulsing of the vital sign area and a drop-down notification. I'll go into more detail about the design later in the presentation. We had 2 main goals. First, evaluate the effect of alerts on documentation, and second, investigate the factors influencing the effectiveness of alerts. I'll briefly review 3 bodies of prior work that are related to this study. Past work examining cognitive aids in time-critical team-based settings found that cognitive aids improve team performance and increase communication. Prior work also explored moving from paper to electronic documentation in archival systems, like electronic health records or flow sheets, finding that data capture increased in the electronic systems. Studies of alerts in electronic documentation found that alerts led to greater accuracy in documented values. Prior studies also explored alert design for clinical decision support in archival systems, finding mixed results. One main issue in this area is alert fatigue, where alerts are overridden or ignored over time. Most prior work has focused on alerts in archival systems. In this study, we explore the design of alerts for cognitive aids. We conducted this study at a Level 1 trauma center in Washington, D.C., where the digital checklist has been used by clinicians since 2017. In this study, we used 2 sets of methods. The first set were for designing the alerts. We used a data analysis to determine the best time to trigger the alerts. We wanted to give clinicians the opportunity to obtain the vital signs before alerting them, but we also did not want to alert clinicians too late in the resuscitation. We conducted design workshops with clinicians at our partnering hospital to determine how to design the alerts on the checklist interface. We also ran usability evaluations before releasing the alerts at the hospital to make sure they worked as expected. Our second set of methods was for evaluating the alerts. We ran an interrupted time series analysis to determine how the alerts affected documentation. We also reviewed video recordings of cases at the hospital from before and after the introduction of alerts. Finally, we interviewed clinicians who had used the checklist to understand their experiences with the alerts. This slide only highlights the 2 sets of methods we used to design and evaluate the alerts. Please refer to the paper for more detail on how we conducted each activity or analysis. Our pre-intervention time period was 2 years. During this time, we ran design workshops and usability evaluation sessions. We released the alerts at the hospital on June 1st, 2020. We then collected data from the checklist for 4 months. During this post-intervention time period, we also conducted interviews with 5 clinicians. Using input from clinicians, we decided on a 2-phase approach to triggering the alerts. In our data analysis, we examined the time between patient arrival and documentation of vital signs in 207 past cases. As the median time was 3.5 minutes between arrival and documentation, we decided to trigger the first alert at 3.5 minutes. As the 75th percentile time was 5 minutes, we triggered the second alert at that time. In the first alert, the undocumented vital signs begin to pulse. I'll play a brief video on the left illustrating the pulsing. In the second alert, a drop-down notification appears, informing leaders of the missing vital sign values. The screenshot on the right shows the drop-down notification at the top of the screen. We released these alerts on the checklist in June and evaluated their impact. From the interrupted time series analysis, we found that alerts led to a significant increase in documentation throughout the post-intervention time period. Although the analysis told us that the alerts led to an increase in documentation, it did not provide any insights into why alerts were more effective in some cases than others. To better understand the factors influencing the effectiveness of alerts, we reviewed videos of cases before and after the introduction of alerts. While reviewing the videos, we focused on the factors causing delays appearing in each case. We found that cases with the external distractions to leadership and leader assists with tasks outside role factors had delayed or missing documentation in cases both before and after the alerts. These findings suggest that visual alerts may not be effective in situations with those delay factors. We also reviewed the videos from the post-intervention time period, specifically focusing on the times and the cases when alerts were triggered on the checklist. We found that alerts were less effective in cases where the team leader was passively or not engaged with the checklist. When the leader was passively engaged with the checklist, they were holding the checklist, but not actively using it when the alerts were triggered. For example, they might have been talking to a team member or watching the examination. In the not engaged category, leaders had set the checklist down to perform another activity, such as assisting with the examination or talking to the patient. In our interviews with clinicians, they discussed how the alerts reminded them to document the vital signs. They explained how they started documenting vital signs earlier in cases, and as a result, started seeing fewer alerts. One leader discussed how documenting the vital signs refocused them on the values, and that documenting the values earlier in cases provided a baseline that they could reference later. We also asked the clinicians if they had any suggested changes to the alerts. One leader described that they liked the pulsing alert better than the drop-down alert because they found the drop-down alert to be too distracting and worried that it could take away from patient care. From our work, we proposed 3 approaches for designing alerts on cognitive aids. As mentioned earlier, alert fatigue is a main issue in alert design. Prior work has suggested that alert fatigue is caused by cognitive overload and desensitization. Our design may have avoided cognitive overload and desensitization as we grouped alerts for the vital signs together, and leaders started seeing less alerts as they entered vital signs earlier in cases. Additionally, 2 approaches to triggering alerts emerged from our research. In the time-based approach, which is what we used here, alerts are triggered after a period of time. However, in our interviews with clinicians, they suggested triggering alerts between the primary and secondary surveys. This suggests a process-based approach, where alerts are triggered after a certain point in the process. In the time-based approach, alerts can be triggered too late if the event is very fast-moving. In the process-based approach, alerts could be triggered too late if the team gets delayed at a certain point in the process. It could be best to use a combination of both approaches in some settings. We also suggest a multi-phase approach for triggering alerts, as teams in these fast-paced settings may be interrupted while trying to satisfy the alerts. Finally, we observed some situations where visual alerts were not effective. Visual alerts are one way to notify the team of information. However, other modalities may be required in some situations. Future work is required to better understand these situations and the types of alerts that should be used. In the future, we plan to explore how the entered vital sign values can be used to provide decision support insights to the team leader. That concludes my presentation. Thank you for listening.